Welcome to the Geriatrics podcast. This is Eric Guidera.
This is Alex Smith.
And Alex, this is a live podcast at the HPNA AAHPM annual meeting. And who do we have with us?
We have a wonderful panel of guests, and today they're going to introduce themselves, starting with Marie.
Hey everyone, I'm Marie Bakitas, and I'm a professor at the University of Alabama at Birmingham, and also the Associate Director of the Center for Palliative and Supportive Care.
Hi, everyone. I'm Yael Shenker. I'm a professor of medicine at the University of Pittsburgh and also director of the Palliative Research Center.
Hi, everyone. I'm Na Ouyang. I'm a PhD candidate at Yale School of Nursing.
Great. So we got a lot to talk about. We're going to be talking about 3 different articles that are going to be presented Saturday, I believe, at the annual meeting. But before we get into the topics, I think we have a song request. You have a song request?
Yes. I requested the song name is The Sound of Silence.
Why did you pick The Sound of Silence?
I like this song very much, first of all. And also I think it implies something nowadays.
Anything else from our colleagues? Or how about we just jump into the song? Maybe they'll sing along.
Let's hear the song.
Yeah, let's hear the song.
Hello, darkness, my old friend. I've come to talk with you again because a vision softly creeping left its seeds while I was sleeping, and the vision that was planted in my brain still remains within the sound of silence. In restless streams I walked alone, narrow streets of cobblestone, beneath the halo of a street lamp. I turned the collar to the cold and damp, while my eyes were stabbed by the flash of the neon light that split the night and touched the sound of silence.
Excellent. Thank you, Alex.
Yeah, I think that song is a protest song that fits our time about people not listening to each other and how in times of turmoil we need to listen to each other and not the neon gods we've made. Who could that refer to? We'll do those verses at the end. Yeah.
Maybe I may sing along then. We'll see. Have to see. Well, let's jump into it. We've got a lot to talk about. 3 different articles. Maria, I'm going to start off with you. You did a rural tele-palliative care consultation study. Before you tell me actually what you did, why did you decide to do this study with your group?
So living in Alabama, which is our palliative care desert in the South, there were no palliative care services in any of the small rural hospitals. And so we decided that we needed to bring palliative care there. It wasn't realistic to bring it by people. And so the video consult was what became the mode. We went to a hospital in Mississippi, one in Alabama, and one in South Carolina.
And what did you actually do?
So probably the most important thing is we developed the consultation as a culturally based consultation process. And so we worked closely with a community advisory group who, through focus groups, told us how it was that Black and white individuals with serious illness had wanted to be treated. So their caregivers did focus groups, and then we incorporated that information into the consultation process, NCP guideline standard consultation. And so really this whole thing was very focused on dealing not only with the issues of rural, but also the diverse cultures that we have.
Yeah. I got to ask about the community advisor. I think I saw a poster on this. Was it Sarah?
Sheena.
Sheena.
Dr. Sheena Gazaway, yes.
She had a wonderful poster. And, I guess one question is, like, when you do these community advisory boards, like, what communities are you including? I'm just trying to think of, like, there was a study of Eric Widera, and Eric Widera was not included in the community advisory board, but you had to put together a community advisory board about Eric Widera. Like, what communities would have been included for that study? Like, would you include the doctors that I work with, healthcare providers, where I live in Marin? I don't want those people to be making decisions for me, so I don't want my Marin community to, how do you think about community advisory boards when people have a lot of intersectionality, beliefs, cultures, even within a community?
Sure. So the community that was the one we tapped for the original study was an R21. Dr. Renee Elk ran that. I was a consultant. And the community was in Beaufort, South Carolina, which has a mix of people who have had experiences with slavery, with deeply held religious beliefs, and both black and white cultures, and very rural. So there was a smattering of people who did the original focus groups, and it was fairly homogenous. I mean, there were differences. Actually, the black individuals wanted to have a separate one from the white individuals, and so we took that into account in the tailoring of our consultation. And so it was really the patients, the caregivers, the family members were the ones who were sort of the closest in observing. Later on, of course, we added health professionals to, give us more information, community leaders, and definitely faith community leaders.
And then what was in the palliative care syringe? What was the intervention?
So the intervention was, it took us about a year to incorporate and then get feedback on the aspects of palliative care consultation that needed to be sort of tweaked. So I'll give you a very easy example. We were told that patients wanted to be treated with respect, to be called Mr. or Mrs., unless they were told the clinician something different. They didn't want you to use jargon. They wanted you to be respectful of their cultural beliefs and their, faith beliefs that were driving their health and illness. And so there were things that we incorporated into the consultation that then the remote doctors were doing the video consultation. They went through an immersion training over a couple of days to really learn about how people wanted to be addressed with palliative care. And so those, I think, were kind of some of the main things.
And then the actual, so you were doing teleconsultations, right?
So the rest of it was, the physicians learned how to do this, and then because they were doing it remotely,
so they were sitting in an office or a home
they're
somewhere.
sitting in their home, in their office, and there is a local nurse research coordinator at each of these 3 rural hospitals, and they recruited patients. Another very important feature of the culturally based consultation was that we had a community advisory group at every single hospital. And so those community advisory group members, one of them would come in with the research coordinator to actually recruit the patient. So they were the first one to talk to the patient locally. They're a member of the community, they know everybody, and they would say, we helped to help design the study. We think this is a good thing for you to do.
Yeah.
And then the consultation would happen.
And was it just with a physician, or was there an interprofessional team?
So in this case, it was just with the physician, though the nurse coordinator was there present during the whole consultation. And then they, so just think of the way that you usually do, your consultations, and beginning with, hello, but they did something different. They said, well, you're in Alex City, Alabama, and I know such and such or so-and-so about Alex City. And, do you know so-and-so? So they made a connection.
Building trust.
Right? Building trust and rapport. That gave the patient the idea that this is somebody who kind of knows something about
This is not just
me.
a random
Talking
doctor
head.
in New York City
That's right.
doing consultations rurally. This
That's
is somebody
right.
who knows
Somebody
the area.
who knows you and me and my community and about my family and those kinds of things. So that was established up front. Then after the end of the consultation, so there's the idea of bringing video equipment in and all that. The nurse coordinator then followed up 3 days and 6 days later to see were there any questions, were the recommendations that were being made, being followed, and then we did our, assessment measures.
Was it just a one-time visit, or did you follow people over time?
So it was the one-time visit by the physician, but then the follow-up happened at day 3. By then, they usually were out of the hospital, actually.
Okay.
So they called them at home, and then also at day 6.
And who was included? What kind of, all patients hospitalized, patients with serious illness, patients with cancer, patients
Sure.
with...
So it ended up, we were looking at the typical admissions to the hospital. Keep in mind, just as we started, so did COVID. So ultimately, our intended audience were people 55 and older, black or white race, and at least one condition that was a cancer or non-cancer progressive chronic illness.
So one serious illness. Did I have to, severity of that? Like if you had just some mild COPD to count if you're being hospitalized?
Yes.
Okay.
And they had to have a family caregiver.
Other questions from the groups before we do the results?
What was most challenging? So all of this was happening during COVID, and I can imagine there were a few distractions. What was the hardest part?
Well, pivoting. In fact, our small rural hospital in Mississippi actually never recruited a single patient in the first year because where it was located, only people who, and I forgot to mention in the eligibility criteria, they had to be living at home and they couldn't be in hospice already. And so the people that were getting admitted were people who couldn't afford to go anywhere else.
Yeah.
And so the most challenging part was trying to get the population that we had banked on in terms of our recruitment to get a normal population that's typically admitted to the hospital. And then because no one could come in, we had intended for their family member to be there. Their family members could not come in. We had intended for the community advisor group to come in and do the thing, so they couldn't come in. But the community members and our team, I'll attribute Dr. Sheena Gazaway, came up with, they made videos. And so the coordinator would bring in the video on a little tablet and say, your community members helped to develop this.
Yeah.
Here they are. And so that ended up being really successful. But, the idea of doing anything inpatient during COVID, was kind of our worst nightmare.
Yeah.
Question. Could you talk a little bit about the other arm of the trial? I think it was usual care, and whether that included in-person palliative care consultation.
So usual care in a small, 80-bed rural hospital includes what usual care is for people admitted to a small 80-bed rural hospital. There was no palliative care there. There were no specialists there, only hospitalists. And so if there was any specialty care needed, well, they didn't get it.
Okay. Big reveal. Did palliative teleconsultation to rural hospitals, did it work?
Yes.
What were the outcomes?
Yes,
what did it show?
And no. So our primary outcome was symptom distress measured by a very familiar tool, the Edmonton Symptom Assessment Scale. And we had a greater decrease in symptom intensity at day 7 versus the usual care group by both a clinically meaningful and a statistically significant difference. Our other measures, in retrospect, were probably not the best ones to pick for an acute intervention because we only followed patients to day 30 for this intervention. Yeah. Quality of life measured by a PROMIS tool was not any different, and resource utilization was very low in all the groups. It was not very different. It was not different.
So it's hard to improve resource utilization for these people, where some of them didn't sound like the sickest of people admitting them to the hospital, but all had some type of serious illness.
It wasn't a eligibility criteria, but all of our patients were palliative performance scale of 70 or greater.
Okay. And then I'd also imagine from a quality of life perspective, like a one-time visit by a palliative care provider, I can't imagine it really significantly improving quality of life unless there was robust, like the one-time symptom was just
right. And even if it made a difference, which I'm not sure that it did, every other study that showed, including some of my own, improved quality of life wasn't measured until like 6 months later. And so I think that, the quality of life was probably not the best measure. Yeah. And we actually measured it in both patients and family caregivers. So we had the same tool that we measured in both, and there was no difference. But again, hindsight's 20/20. Probably wasn't the best measure to look. The other one we tested in an exploratory way was feeling heard and understood. And so I'm going to reserve the results of that, which wasn't different, but were interesting for another day or question.
Okay. So my last question about this before we move on is, we had a podcast on telepalliative care in the community, going to people's homes, really showing, was it non-inferior? I forget what the actual equivalence. I think that was the equivalence one. For this one, is there something about acute hospitalization where being in person, how much does that matter for the non-symptom stuff, you think? Like the building trust, the getting to know people, just seeing what's going on in the room, like reading the room. How much of that is just the importance of being in person versus how much of that do you think it doesn't matter if it's in person or teleconsultation?
I actually don't think it matters. If you can establish rapport and if you do good telehealth etiquette, which is seeing who else is in the room, addressing everybody that was there, et cetera, they had requested in their cultural tailing that the physician wore a white coat when he was going to be seen on the screen. And so I think that really it didn't matter if you could develop rapport and respect. And so our objective data about that is we had a 10-item telehealth satisfaction measure. That's a common one that's been used. Yeah. And we had greater than 95% agree or strongly agree to the satisfaction with doing the telecount. Would you do it again?
So people liked it.
They absolutely thought it was great.
When can you bill for this? Like, if we started this today, could clinicians bill for the video palliative care visits?
99 something CPT code.
So this is a moving target right now because the emergency pandemic telehealth regulations that were waived have sunsetted as of January 1st. And so I'm not really sure.
Okay.
I think there's no reason why, if you could bill for a telehealth visit inpatient, then you certainly would be able to bill for this one. But I think right now it is a moving target about that. So we'll have to kind of wait and see.
Okay, last quick question. When you say telehealth, you mean like video health, like so you could see each other?
Yes. So we are very clear throughout our reports that this is a video consultation. Mm-hmm.
And did people get advanced care planning?
Good transition.
I want to ask Yael about the advanced care planning. So the answer was yes, but not the way that Yael did it.
Yael, so you did a study on advanced care planning.
I did.
What motivated you to do this study?
Yeah, it's a great question. I think my motivations are similar to Marie's, actually. It's all about how can we make, for me, advanced cancer care more patient-centered, recognizing that most people don't have access to a palliative care specialist. And, we've looked at that in a couple of different ways. We did a large primary palliative care trial. We gave these tools to oncology infusion room nurses. That was, complicated. That was my prior Jerry Powell appearance. This, for me, in advanced care planning, the way I think about it's really giving tools to patients and families. And it, is guideline recommended in advanced cancer, but there are a lot of different ways to do advanced care planning. I think we all recognize that. And so the question that motivated this trial was, which approach is best?
And what did you actually do in the study?
So we compared two different ways to do advanced care planning that are pretty different in terms of the resources and the complexity. So one was, patient-directed advanced care planning. We used Prepare for Your Care, written and web-based tools.
Oh, our own Rebecca Sidori at UCSF?
Yes, and I'll say this is, when I say we, this is a huge group of incredibly committed people, including Rebecca from Prepare for Your Care and Bud Hams from Respecting Choices. And what we compared the patient-directed arm to was a facilitated advanced care planning approach using Respecting Choices.
And when you say facilitated, what does that mean again?
So facilitated means we had nurses who weren't otherwise part of people's cancer care teams who were trained using the Respecting Choices model. They went through a 3-day training. They were certified. And then they had visits with patients, and families were invited but not required to walk through the steps of advanced care planning using the Respecting Choices
So
materials.
one group just got Prepare for Your Care, which you don't need a facilitator. You just email them or email them information on Prepare for Your Care. They do the homework. They talk about it then with their doctor or their healthcare provider.
Yeah, and so, Prepare for Your Care, the way we did it, we really left it up to people to do this on their own time at home. We made up to 3 reminder calls, but it was very different from bringing people into like a research office and going through all the steps. And
the facilitated one was not group visits, it's one-on-one, so resource intensive.
Yes, exactly.
So this is a resource intensive advanced care planning versus resource light.
Exactly.
And what was your primary outcome that you were looking at?
So our primary outcome was a very patient-centered outcome. It was engagement in advanced care planning. It's using a validated scale that measures sort of patients' behaviors, on multiple different advanced care planning behaviors. So not just, is there a form, but, thinking about sort of their readiness and self-efficacy for things like identifying a surrogate and talking with family, talking with physicians. So it's a validated scale. It was developed as a huge long survey. I think it was 82 items. The one we used was 15 items.
So I got a question then.
Yes.
So I'd imagine like if I'm doing a smoking cessation study.
Yes.
Should my primary outcome be engagement in the idea of smoking cessation, or should it be smoking cessation?
So I think it's a fair question, and I think this question of outcomes of advanced care planning, what's important, obviously has been a subject of debate in our field, and a lot of that debate happened after we had sort of designed our trial. But what I will say is, and what I think is really important when we think about advanced care planning, it's not a single outcome. So we also had, looked at advanced directive completion, we looked at other advanced care planning sort of action outcomes, and then we enrolled patients and caregivers. We followed patients until they died or the end of the study period, whichever came first. And then we did interviews with bereaved caregivers, and we asked about distress and goal concordant end-of-life care. So we had a whole range of outcomes.
I love that because, you completely destroyed my argument because smoking cessation, we do want people to smoke, but ultimately, the advanced directive is a middle piece. It's not like advanced care planning is a process, and an advanced directive is just one thing. You can think about it like hospital utilization, but if it's really goal concurrent care, hospital utilization is not the most important thing. So what is the right outcome we should be looking at?
Leave that open for the
Maria,
panel.
you're going to say something?
Yeah, that might be a whole separate podcast.
Well, if there was one, what is there one? Could you think of one? Maria, you were going to say something.
Oh, no.
You're staying away.
I was going to say that it is very tricky. It's very tricky. Outcomes are very tricky in palliative care in general because, typically in other, drug studies and things, they measure survival, right? And so that's pretty easy. That's
Not anymore. We're using all these surrogates
Yes,
now.
no. And so
amyloid status, disease progression-free survival, things that are much harder to even.
Right. And so it's hard. It's really hard to think about what is the best outcome because you couldn't follow everyone till they died and then find out after the fact from these family members whether your intervention helped that process. I was really wondering what you did find from the people that you did interview the family members about after the fact.
Yeah, so I can share the findings, and I totally agree. And the other thing I'll say about, outcomes of advanced care planning. So absolutely it is complicated. I think there's not a single most important outcome. We have sort of talked about this as a field, and there was a big Delphi study, many of you were probably part of it, that Rebecca Sidori actually led, where we had to rank, it was like 125 outcomes or something. And so we've thought about this, and goal concordant care definitely was the top. But below that were all of these action outcomes that people see as important, as far as advanced care planning. So, was there a conversation with family? Was there a conversation with physicians? Was a surrogate designated? Was there something in the chart about goals of care? Were values elicited? So we thought about all of that, and when we designed our trial, our primary outcome, and I can share what we found.
Was there a difference between resource intensive versus not?
Yeah, so there was a difference. I'll say all of our advanced care planning action outcomes increased in both arms, but engagement in advanced care planning, our primary outcome, increased more in the facilitated arm, so the resource-intensive arm, and it was both statistically and clinically significant on that scale. And then what was kind of most surprising and most, interesting for me was this consistent story when we followed, patients through mortality and did our interviews with bereaved caregivers. We found lower distress using a validated scale among bereaved caregivers who had participated in the facilitated advanced care planning arm. So that was lower PTSD symptoms using the IESR scale. And then we also found higher reports of goal concordant end-of-life care. So caregivers in the facilitated arm were more likely to report that their loved one received care at the end of life that aligned with what they would have wanted. So it was a pretty consistent story about the value of a more resource-intensive
Marie's super excited.
approach.
She's excited.
So I want to know if I'm not supposed to be taking this away from you, but
No, take it away.
It's a duet. Marie.
if you learned, if there was where the person died had anything to do with also the family member outcomes. So were there differences in where they died, and did that make a difference?
So did it make a difference? So we did look at where they died, and we looked at whether they died where they would have wanted to die by asking caregivers, with those questions sort of separated in a long survey in an attempt to minimize bias. Perhaps not surprisingly, most people wanted to die at home. Mm-hmm. A smaller number died at home. We didn't find, and we weren't powered to look at whether there were differences between arms in whether people died in their preferred location, although there may be a suggestion there, and that might be something to think about for larger trials and sort of talk about what we want to do next. But I think that's a really important piece of how we sort of think about goal concordance.
Speaking of larger trials,
yes,
there was a study that was recently published, which I think we're doing a podcast that will be published in a couple of weeks, on advanced care planning of community dwelling, I think older adults greater than 65, using facilitated, I think, advanced care planning versus kind of usual care. I think there was an increase in advanced care planning documentation, but the group that got the intervention had higher rates of potentially burdensome care. It's been a while since I looked at that. Does this ring a bell to you, Yael?
It does ring a bell, and I hope we're thinking about the same one.
It came out, I think, in December, and JAMA.
Yeah. So I think so. I mean, a couple things to say. I think when we talk about facilitated, we're not always talking about the same thing, and there are different levels of facilitation. And so our facilitation, this was, a trained nurse who met for, it was on average like just under an hour. Yeah. It wasn't just, can we get people to do this thing? It was really sort of an emotional support plus advanced care planning visit, which I think, and we have qualitative data that we're analyzing. We're hearing a lot about the value of that and what that sort of meant to these patients and families in that time in advanced cancer. So I think that's one piece. When we say facilitation, it can be many different things.
But what if, since you brought up the word value, what if increasing goal concurrent care means there may be an increase in burdensome treatments at the end of life. Is advanced care planning, again, we're going to have a podcast on this particular subject. Is that a worthwhile goal then?
Yeah, and so I think that's a very fair question. Gets back to this debate in our field about what the important outcomes are. I think the most important outcomes are what matters most to patients and families. Those are hard to measure, right? It's a lot easier to look in the medical record and see what healthcare utilization looked like at the end of life. And I think we have different stakeholders with different priorities, but I still think what matters most to patients and families and the idea of alleviating distress amongst bereaved families, which we know is such an important part of what advanced care planning accomplishes. I think that's important. We are going to have healthcare utilization data as well. You know, all of these trials have to look at this from multiple angles, and I don't have that data to share yet, but we will also look at that.
Yeah, I wonder what the take-home is from this study. When I think about what your findings are, like on a population level, it's much more affordable if we could get everybody to prepare, everybody with serious illness, for example. However, you did find what you said was a clinically meaningful difference in outcomes for people who had the facilitated advanced care planning, which is much more resource intensive. What ought we as a society do from a health policy perspective with these data?
Yeah, so I mean, I think one take home from this study is that advanced care planning is really hard to do. And we're hearing this in our, interview data now. When people have advanced cancer, they are navigating so many things. And, this is really hard to do. And so for some people, that additional, facilitation piece is super important. There are other people for whom having access to those incredible, patient, friendly, easy to read, multilingual materials is the perfect thing. And so what we're thinking about next is sort of a stepped care approach to advanced care planning. I know you guys have talked about step care approaches to chronic care. But, can we start with something less resource intensive and step people up if they don't engage or respond?
Great, thank you.
And I also love, as a clinician, I love the idea of just, and I think this is like it's in Rebecca Sidori's preparing people, and importantly, family members for really, really hard decisions that come up, because if something happens, they're the ones that are like still alive in bereaved family member situations, which kind of brings us to our third article. I don't think this is our first time that we've had a pediatric article. Is it the first time? No, I think we've had one more.
Pediatricians on.
We've had pediatricians
but not
on.
Pediatric articles per se.
Yeah.
So you're right. I think this is the first time.
So let's turn to our third article. And I want to make sure I'm pronouncing it. Is it Na?
Yeah.
Great. Why did you do your study?
Yes. So first, my study focused on early bereaved parents, which means those parents who lost their child in the first 2 years, which is extremely vulnerable time. They experienced a lot of prolonged grief symptoms. And I also realized the communication between parent and clinician is really hard, especially among those parents whose child with incurable cancer. Those communications are always very challenging. And I was wondering whether the communication can impact their grief, even though that's maybe a long period between grief and communication during treatment. And then I'm also curious whether parents perceived their end-of-life preparation can help them to relieve their grief symptoms. So my research is kind of focused on explore the relationship between communication and the grief in the early bereavement stage.
And tell me, what did you do in this study?
Yes, so we did a secondary data analysis, actually. The data set is from Dr. Jennifer Seinemann. She's a pediatric oncologist at Dana-Farber. She collected data from St. Jude and Dana-Farber, asked those parents who, in the early bereavement stage, their experience, and they record their child's treatment experience. So that's a very, very large survey. That survey included like 195 items. But they developed the survey involved a lot of brave parents to have their input to develop the survey and in every stage of development of the study.
Yeah.
So that's a really awesome data set. And they have 125 participants in that data set. So I did
125 bereaved family members, so
Early
parents,
bereaved, yeah.
early bereaved within the first 2 years.
Yes.
And what was the primary outcome that you were looking at?
Yeah, so my primary outcome is prolonged grief symptoms.
Okay.
So that's measured by the 13-item prolonged grief disorder instrument. It's a validated instrument. And we calculate the sum score. The sum score, the higher score indicating greater severity of prolonged grief symptoms.
And what'd you find?
We find actually we have 3 community variables, which is the quality of communication and the amount of prognostic information and trust in healthcare providers. And interestingly, over 90% of parents said that they trust the healthcare provider a lot, and 80% of them said they have a high quality communication, and 60% of them, they had enough prognostic information, but there are a lot of parents still feel they are not at all prepared for their child's end of life, which makes the results very interesting, because I thought if you have good communication, then you can better prepare. But it seems like they didn't prepare for their child's end of life.
So what I'm hearing is that people trust their doctors. They generally have really good quality of communication with their providers. They're getting some idea of prognosis.
Yeah.
But for a lot of them, they don't feel prepared.
Yeah.
I guess my question is, can you ever feel prepared for the loss of your child?
Yeah, so we did interviews after this data analysis, and we asked the parents. A lot of parents said, you can never prepare for your child's end of life, but there is some level of acceptance and some preparation you can do. Yeah. So,
and it was important because if I remember the abstract correct, it was not at all prepared.
Yeah, like 40% of them
not at all. Not a little bit, not at all prepared.
Yes. Yeah. So we find that the quality of communication and trust doesn't really relate to grief symptoms, but the amount of prognostic information impact parent grief. It's a significant impactor. And when we add the preparation for end of life as a mediator, the pathway, and the effect of prognostic information on grief disappeared. So which means the preparation for end of life is really important from communication to grief.
So am I hearing this right? If you actually want to prepare people for the loss of somebody like their child, the communication about prognosis is incredibly important.
Yes, but also the impact of prognostic information on grief mainly through the pathways.
So
when you say impact, just so we're clear, that means more information about prognosis was associated with less grief.
Yes.
Okay. I was make sure we understand the direction.
So more prognosis,
that's
less
really
grief.
important. Yeah.
And that the way the prognostic, the greater prognostic information results in less grief is through better family preparation, better parental preparation for the loss of their child.
Yes. So that highlights the end-of-life preparation is super important for parents when they deal with their grief.
Right. And I wonder if there are differences between what's said and what's heard. So might it be that the clinicians tried really hard to convey the prognosis and it wasn't heard or reported as being heard?
Yeah, that's a really good point, because that occurs in our interview a lot.
Can you say more about what you mean by that?
Yeah, so we did interviews after the secondary data analysis, and in our interview, some parents said they listened to those information with a filter of hope. So even though you tell the parents your child is going to die, but they still keep the hope that they don't want to prepare for the end of life. But those parents also mentioned they would appreciate if the clinician can use different resources, like connect with other bereaved parents or provide professional support like mental health service or therapist to talk with them, which can help them a little bit to accept that sooner.
I have a question. I could interpret these results in sort of one of two ways. One way is this is a powerful study that shows clinicians' relationships with parents of seriously ill children are strong.
Yeah.
We can rely on the strength of those relationships and that trust to have the difficult conversations about prognosis, to help parents prepare for the death.
Yeah.
The other way I can interpret it more cynically is somewhat in the line of the late great Jane Weeks study published in New England Journal. This was her final publication, I believe, where she found that patient satisfaction with their clinicians, and these are patients who had advanced cancer, was associated with like having less awareness that they had a terminal cancer, right? And so the cynical view is the reason they rated their clinicians so high is because they did not have a good prognostic understanding. And had the clinicians pushed the issue, then maybe satisfaction and trust in their clinicians would have diminished. I don't know. Any thoughts about that from anybody now or anybody else?
I really like your first interpretation.
we all do.
I guess the thing that just strikes me the most is because I think it was it Prigerson's tool that you use for complicated grief, and the things in adults were preparation, or the bereaved family members found that preparation as well as the activities around the death or the circumstances around the death, whether they were traumatized by, like CPR and all that business happening, or, that those two things were really important. And so I'm wondering, it feels like it's a very different situation between adults dying and the family members of adults versus the family of parents of children dying. Do you think there's a big difference?
I think so, because a lot of parents mentioned it's very hard for them to accept that because it's not the natural order. And they said, as a parent, you're not supposed to bury your child. So that's one of the barriers we identified about help parents to prepare for their child's end of life. Like they need to overcome those. We call it they feel defeated when they recognized their child is gonna die. They feel like they should always fight. So There's a lot of barrier among parents, their own mind. Yeah.
Okay, I got one. This is a lightning round question for each of you, because I've noticed in the last couple of weeks I'm sitting with a lot of anger, and I'm recognizing that, and I need to fix it. So I need some positiveness. These studies, each of yours, I can imagine there are periods where, it's incredibly hard, it's frustrating. There are probably periods where you're thinking, why did I decide to do this? But what's one thing that you loved about your study? Marie, one thing you loved about it.
I'd have to say that the people that we met at the rural hospitals, to a person, were so grateful to have any kind of resource or attention or specialty care available. And so it was just really gratifying and helped us through the difficulties.
Great. Thank you. Yael?
I'm going to say the research team. And, I think it's kind of embarrassing to look back at how long we've been working on this project for. And this team has stuck together. COVID hit. We had to pivot. People had to be flexible. Really being willing to ask questions about, advanced care planning models that have been around for, decades in some cases. So I'm just very appreciative of that sort of curiosity and dedication.
Great. Na?
I appreciate all the stories I heard from those parents. at the very beginning, I felt that's so hard to have those conversations when I do this research. But then when I heard them and they gave me a lot of positive feedback, they said what I'm doing matters and very important for them. And then I felt the motivation to keep working.
Well, I want to thank all three of you. Alex, I've come to talk to you again about singing The Sound of Silence. Can you do the disturbed version of Sound of Silence, which is my favorite version of Sound of Silence? No? Have you heard this disturbed
I do know
version?
what you're talking about.
Okay.
Maybe, yeah, maybe not. Here's the Simon and Garfunkel. All right. Fool said, you do not know, no. These are outtakes.
We can do anything now.
Yeah.
But we may keep it in.
You do not know. Silence like a cancer grows. Hear my words that I might teach you. Take my arms that I might reach you. But my words like silent raindrops fell and echoed in the wells of silence. And the people bowed and prayed to the neon god they'd made. And the sign flashed out its warning in the words that it was forming. Then the sign said the words of the prophets are written on the subway walls and tenement halls and whispered in the sound of silence.
Marie,
Woo!
Yael, thank you for joining us on this podcast. Big shout out to Ann Kelly, who's recording us for the video.
Thank you.
And thank you to all of our listeners for your continued support. We'd also like to thank everybody who's donated over $250 to the podcast over the last year, including
Daryl Owens, Craig China, Mike Steinman and Dorothy Richmond, Diane Meyer, Matt Schuster, Harry Hahn, Elizabeth Chung, Wendy Peltier, Kelly Strait, Jeffrey Galbraith, Ron Sabar, Rebecca Goldstein, Anna Lynch, Deborah and Jeffrey Larson, Krista Masak, Ed Martin, Stuart Oserman, Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulsky, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones. Thank you all.